Thanks so much, Susan. You'll be pleased to know I got rid of one of those things. I no longer direct the health management program. Thank goodness. But I guess I was sort of, I love to hear Mark speak. I about fell over when I realized that I was going to speak after Mark, because I always find myself completely just thinking and speaking a different language after I hear him. And then I have to go, okay, wait, what do you do? So I'm going to have to ask you to do the same thing, is to erase for a moment all the very, very small molecular ideas you were thinking about and think gigantic, because my research is really about how marketplaces work, and particularly how care is delivered. And as Susan said, I have studied this in a lot of different areas, but I've always been very interested in the use of hospice as one type of care delivery, and that has brought me into studying patients with cancer. In terms of the global health interest, it actually does tie, because hospice is very poorly used in most of the world. And in low-income countries, nobody actually calls it hospice, but their acute care looks a lot like hospice. They can pretty much give some pain medication, and they can give some hands-on care, but not a lot of other care. So looking at this internationally, I hope will be in our future. What I want to talk with you about, let's see where this goes, today is the quality of care for hospice in the changing marketplace. And I'm just acknowledging here the work is funded by the National Cancer Institute and the Connecticut Hospice. And several of the collaborators are here. Melissa Carlson, who was a doctoral student when we first started working on this, and is now an assistant professor at Mount Sinai. Ruth McCorkle is here, and Jen Thompson. And I don't think the others on here are here. And I have no conflicts of interest. Just a roadmap. My goal is to give a brief background of why this is interesting, what is changing in the marketplace for hospice, some study methods, the current findings we have, and then a little bit of a discussion about what we have found. So I guess to this audience, I really wasn't sure how big you would be or what you would know or what your background was, but I guess I'm not sure how many people know what hospice is. Does everybody here know what hospice is? Yeah, okay, so I am very interested in the hospice industry because it's an incredible laboratory to understand organizational change. It actually began in the United States about 35 years ago, right here on campus, which some of you may recognize, and in New Haven was one of the very first hospices ever given in the US, and it was really run by nurses and volunteers in the bottom of a church. That's where it began, up on Cold Spring Street. So today, this is a gigantic industry. It actually has 5,000 hospices in the country. So we think of it as a really interesting thing to see how it's moved from a grassroots movement, which was really volunteers, demedicalize death, bring it outside of the hospital, think about the nursing role, the whole patient, not just the medical side, kind of very kind of rebellious movement, really, for medical care. But starting as grassroots, and now to move from that in '73 to this major industry of 5,000 hospices nationwide, how has that affected things? How does something like that happen? So over time, the first thing that one will recognize in this industry is hospices have tremendously diversified. So in their beginning, and this was several years after their beginning, but mostly they took care of patients with cancer. They didn't worry too much about patients with Alzheimer's disease or stroke or COPD. But today, more and more, in fact, more than half of the patients who receive hospice services today do not have cancer. So they very much have diversified. Additionally, and as the sort of setup for what we're particularly interested in, hospice has attracted capital markets. So what I mean by that is they have become for-profit. It's a very strong for-profit industry now. And a lot of people take a look at this, and actually I remember being in 1992 and just seeing a little peeking over the horizon that there are maybe 5 to 10, 20% of hospices that are for-profit. And of course, a grassroots movement never starts as a for-profit industry. Like, how does that occur, that you have this infusion of capital to an industry? And we wrote a few grants in 1992 on this issue. 1993, we really should look at this. This is the time where we're seeing a phase change. If ever we want to understand what happens when you bring a for-profit enterprise to a marketplace, this is the time, and no one would fund us. And I think the science we proposed was just as good then. But this trend just continued to grow and continued to grow. And finally, in 2008, I think maybe it was 7, we got the grant to really look at this, to understand what is the difference between the hospices that are nonprofit and the hospices that are for-profit. Is it true that we think that hospices that are for-profit actually give poorer quality care than those that are nonprofit? And this, I think, became an interesting question when the industry now is about half and half. So it's a great experimental group to take a look at in terms of this. With the growth of for-profit industry in this, what had been thought of as sort of, gee, people are dying and we're going to give them the best care we can. How are we making money off of this? With that sense has been a lot of concerns from policymakers and several responses. The fact is that a lot of people have seen that this is an industry now that has gone the way of several other healthcare industries before this. For instance, HMOs actually started as nonprofit entities but are now corporatized. And with that growth have been a lot of concerns about the quality of care and the costs of care. Well, for-profit markets basically create a very costly service and also not as high quality service. The National Quality Forum, which is the association and governmental relationship that sets really quality standards in all of our healthcare delivery, took this issue on in 2006 that said hospice will be a national priority area for quality improvement. In other words, the fears that maybe quality wasn't quite as good in hospice as it had once been. And then in 2009, there are gigantic lobbies and multiple professional associations involved in setting standards for hospice. The National Consensus Project brought those together in 2009 and endorsed a set of clinical practice guidelines, just like their clinical practice guidelines in cardiovascular care. Some, I believe, in cancer care, or not so many. These were really developed for hospice in 2009. So this gave us an opportunity to say the industry's changed a lot. Now we have guidelines to know what is quality in hospice, and let's study about whether the nonprofits or the for-profits are really different or not different in this industry. So it makes sense what we're doing, why we're doing? Okay, keep going, right? So research question was, so what is the state of clinical practice guideline implementation? Are the hospices doing what you would say are the preferred practice among hospice nationally? And how does it vary? Does it vary by hospice type or location? And we are particularly interested in ownership. That means for-profit versus not-for-profit. But we also wanted to take a look at whether there were variation in quality based on size, chain affiliation, geography, etc. The ownership question, we actually had a history of, in 2004, Melissa and I worked on a paper to understand what was it that was somewhat different in the for-profits. And in those days, what we found were two pieces. One, that they had offered a much lower scope of services, so where you might get clergy and social work and medical care and nursing care and palliation in a nonprofit hospice, the scope that you might get in a for-profit hospice was significantly narrower. And for-profit hospices were also less likely to use the highly trained staff, such as RN versus LPN nurses, or medical social workers versus counselors. So we had this indication that maybe the for-profits are skimping or slightly delivering less, but we really didn't know in today's world, but that is where the hypothesis came from. So in terms of methods to try to study this, we used a cross-sectional survey of a random sample of Medicare certified hospices in 2008 and 2009. For those of you who do survey research, I hope you'll be impressed by a response rate of 84%. To get organizations to respond to something like this was significant, and that took quite some time to do. We also looked at the non-respondents nonetheless, and they did not differ by the variables we had, which was geographic location or ownership. And what we did was basically ask hospices, so we have a self-reporting issue here most likely. However, we asked hospices if they were implementing a variety of what we knew from the clinical guidelines were preferred practices or clinical guideline-based issues. Now, these things are quite objective, so it's a little bit difficult to completely lie about these things. They're fairly objective. They also were not that well known at the time of the survey. In fact, the documents were given to us through governmental agencies and professional associations, but there were no laws about this. So it wasn't the type of thing that every hospice would say, you got to say yes to that or you're going to be shut down. There was nothing like that. They really weren't as well known at that time. The multivariable analysis that we used with hospice was the unit of analysis, and we looked at multiple quality outcomes. In fact, 20 outcomes we looked at related to these quality measures, and we had several covariates, as I've talked about before: geographic location, ownership, whether they're part of a chain, are they vertically integrated, meaning are they owning multiple parts of the healthcare, including hospitals, hospices, home care, etc., how big they were as hospices, and how many years since they had been accredited or certified as a Medicare hospice. So the quality domains that we looked at were three. We think about, what does a hospice actually do? When a patient dies, they are both giving service to a patient, but there's a ripple when someone dies to the family, has to sort of absorb the shock, and hospice technically sees patients and families as the unit of care. So we thought we could look at the way they treated families, what their policies were about that. But hospice even goes further than that. Again, a death creates a ripple, so to the family and then to the community. Is hospice really doing the things in the community that are considered sort of the preferred practices of really a high-quality hospice? So from the guidelines, we developed measures of these in these three domains: 10 measures along patient guidelines, 7 measures in family guidelines, and 3 measures in community-type practices. This is what the sample of hospices looked like. It was a random sample of 591 hospices, and you can see sort of the size. 15% were part of chains, and the 48% nonprofit, 48% for-profit very much reflected the industry. So we felt we got a good representative sample. Again, very much reflected the industry, about the portion of hospices distributed across the country. And I won't go through each of these because I want to get to the main punchline and see if you have any questions. But just to give some sense, as looking at the 10 patient quality measures, and on this a few of them are within one bullet, but more than 80% of hospices reported these top ones. Things like, so you have a sense of it, do you provide 24-hour crisis management care? Okay, 80% or more of hospices did that. The third one down, do you track patient satisfaction? Do you track safety? The fourth one down, do you monitor pain at least every few days? Do you have a physician 24/7? These are kind of, if you're a quality hospice, you'll be able to answer yes to these, and the majority did. However, less common were some of the issues at the bottom. For instance, the very bottom one, do you involve the patient's goals of care when you actually discuss the plan of care? Are you thinking about the patient's goals, etc.? So we could sort of rank these in terms of how many hospices did each. Family, again, we had 7 of these. A couple are within one bullet, but more than 80% of hospices. For instance, on the second one, the question, do you screen family members who may be at risk for major depression? Earlier studies we had done had demonstrated that depending on the care of the family during hospice, they really recovered well or didn't, so in terms of depression. So some of these come from that. And again, you see some variation with some of these done by most, but several of these less prevalent among some hospices. And then last, 3 measures of community relationships and what were considered preferred practices, and you get some sense of the distribution. Overall, we looked at these and we said, well, a lot of hospices are doing a lot of these good things, at least by their self-report. However, if we tried to take a look a little more deeply at, but are they doing everything? Or are they spread throughout? So on average, they look like 80% are doing that, but it's not the same 80% that are doing the other. If we actually look at how many hospices meet all 10 patient domain preferred practices, only about 20% met all 10. And you can see for the family, about a quarter, and for all 3 of the community preferred practices, less than 15%. And then if we put all of them together, the highest bar of do you meet all 20 preferred practices, very, very few could be found that would say yes to that. So of course, given our interest, our main question here was, okay, and are we going to find that if we consider our outcome, yes, no, or a continuous variable there, are we going to find that the for-profits are less likely to meet these quality measures, or are we actually going to find they're more likely? I mean, you could think they're more likely because they're efficient and they're fast, and they get a lot of literature in management of they get standards and they just plaster them throughout the corporation. There's no sort of, oh, if it's good, do it, the way a nonprofit might be more flexible. So you could sort of see it going either way. We hypothesized that it would be, for-profits would be less likely to implement all these things. So this is a result of logistic regression, where the outcome is the yes, no, we've met all 10 patient-preferred practices. And in blue are the actually statistically significant correlates of meeting all 10 preferred practices for patients. And you can see what this shows in blue is that the larger hospices are the ones that are more likely to meet the 10 patient-preferred practices, and those that are in a chain are also more likely to meet the preferred 10 practices. But what is not here is ownership, and that's because it was not significant. So it didn't matter. And this was looked at both bivariate and multivariate. Didn't matter even in a bivariate analysis. Additionally, it was, we looked a lot at, should we measure 1 through 10? Should we measure dichotomous? Looked at this a lot of ways, and you could not find data that the for-profits and the nonprofits differed in their quality. Did the same in the family domain. And again, size, very important. Part of a chain, important. Nothing about ownership. It's a negative study. Then we looked at the community, and size matters a lot, and being part of a chain matters a lot. Ownership does not matter. So needless to say, the nonprofit lobby for hospices in the United States is not happy about these findings, because they really are very intimidated by the fact that for-profit hospices are now potentially taking their market share. And we looked at very carefully whether we could see differences in for-profit and not-for-profit hospices, and they cannot be found, at least in these data. The one place that I think there is some evidence that potentially there will be a finding in terms of for-profit is in their really engagement with community outreach groups. And that's like one of the three. And it's marginally different, with the for-profits less likely to do that. But I think in general, I don't know, we talk about it a lot, but we really can't conclude from this that we need to say, oh no, the whole industry is going for-profit, what are we going to do about this? Now, just in terms of the discussion of that, I think what has become important from this work, from our perspective, is a minority of hospices report meeting all the preferred practices. So that in itself, understanding, that's probably a problem. Now, it could be a problem with the recommendations. Maybe they're too strict. And we don't have the evidence the way you might have in a clinical trial, where if you do these, then actually patients are more satisfied. Nobody has that evidence to date. I think the policy movements are to try to gather that data to be able to really get some evidence base behind the preferred practices. But for now, those preferred practices are more a consensus document than an evidence-based document. Nonetheless, a minority are meeting that, and maybe that's cause for concern. There is, however, as discussion point, no evidence that ownership is associated with any system in any systematic way for reporting implementation of preferred practices or not. This actually is quite consistent with some other industries now. Once an industry is 50-50, organizations to survive copy the others. So it's hard to say we see no difference, but we can't really tell from that because we don't have the longitudinal look over 20 years to say the nonprofits have just started to look like a for-profit and no one's really doing it as well as they should have, or whether the for-profits actually have started to mimic the nonprofits and have elevated the quality that they might, as compared to where they began. We can't know that because it's not longitudinal. We do find, nonetheless, that large size and being part of a chain are consistently associated with reporting better preferred practices, or more likelihood to report those preferred practices. And that, I think, is pretty important in terms of the smaller hospices, what we do. So in terms of the sort of implications, the previous work that we had done had shown differences in staffing patterns, scope of services, and that was true even after adjusting for size. But the ownership differences appear to have attenuated at this point in contemporary practice, with, I think, the take-home message, there's room for improvement in both sides of this industry. I would just sort of end with this point that quality measurement in hospice is really in its infancy. And if we look at cardiovascular care today, the quality measurement, the pay for performance, a huge amount of evidence and research that's gone into that. In hospice, not really. It's sort of like a cowboy field right now. Nobody has really done that much work in the quality of hospice. And more evidence about the impact of these preferred practices is definitely needed. The industry remains tremendously turbulent. Actually, the most recent data is showing over a decade about 20% of hospices come or go. So there's a lot of turbulence, a lot of these small hospices where I think the cause for concern about quality probably should be targeted as opposed to the concerns about for-profit hospice. And that's it. Thank you.